My name is Ralph Corsetti. I'm a breast surgeon, surgical oncologist. I'm a professor of surgery at Tulane University School of Medicine in New Orleans. And I've been a Scout user for greater than 5 years. I've been a Scout user for over 5 years. Prior to that, we had used magnet technology, and what I found with the magnet technology, it was very unreliable in terms of being able to find the area that was localized. I would often have the probe in my hand and place it on the breast and often not get a signal at all, and then as I withdrew the probe from the breast, I was getting a signal. And so I never really understood the physics and the mechanism of why that was happening. The probe would go out to get reprocessed, and it would come back and it would work well for a few weeks, and then it would start happening again. So we began to trial other technologies such as Scout. We also tried the hologic localizer. I think I trialed 8 localizer cases in my practice, and I found that 3 of those 8 had significant slippage where the localizer seed was not in the area where it had been originally deployed. I'm not sure if it had been deployed in compression under mammographic guidance, and then when the localizer seed came out of, the breast came out of compression, the seed moved. So I found that to be an unreliable part of that. Another thing that I really like about the Scout, and having, again, used the magnetic products, having used the hologic radio frequency products, is that those are very smoothly contoured products for the most part. There's some ridging on the magnets, and the hologic is smooth. But the Savvy Scout, I think, without really knowing about it, the fact that the 2 antennae kind of create a dual barbed effect. So there's no migration, there's no slippage with the deployment. Because there's that central piece that's a little thicker than the antenna, once it's deployed, it just doesn't want to move forward or backward. And you think if it's going to move in that plane because it's like a little arrow back and forth, but the little thickness in the middle just keeps it from moving and migrating. And so when you go do your case, it's always where the radiologist had deployed it. And that was another issue I'd had with the other products, was a migration or slippage issue. Scout really, I think, covered every angle for me in my practice. Its depth of penetration, where you can come in and pick up the area from at least a 6 centimeter distance. Having used wires for the 25 years I'd been in practice, for the first 20 years of my practice, having used wires, you kind of have a general idea where the area is. So if you're not getting a signal on the surface, you kind of know the general area where you're going to make your incisions, and then as you get into the parenchyma, it's easy to pick up the signal. It's three-dimensional, 360 degrees in terms of its pickup. As you begin to rotate the probe tip, you can really hone in and focus on the intensity of the signal. It measures the distance, and I think it allows me to, the probes come in different thicknesses, so it allows me to get into the area I need to get into. And so it's magnet safe in terms of MRI. So we do a lot of neoadjuvant chemotherapy in our practice. So it allows us to deploy a seed or a marker that's not going to deploy a MRI signal and cause artifact where you're not seeing your MRI more accurately as you get a post-treatment MRI following completion of the neoadjuvant chemotherapy before you take up the surgery. So those are some of the reasons why. So another reason I use it, again, is when we do neoadjuvant chemotherapy and we have positive nodes to begin with, we put these markers in the lymph nodes. Because it's a retro deployment, our breast radiologist actually finds it easier to penetrate the lymph node and then deploy it as he's pulling out, rather than try to deploy it into the lymph node. He's found that he's had better success with deployment of the marker actually into the lymph node, which is great, because you want that marker to be in the lymph node, because as that lymph node disappears from the chemotherapy, you want to have your marker in exactly the spot where the cancer had been, not next to the lymph node, because you may not sample that as accurately once the time comes for surgery. My thoughts is that you need to be, a careful surgeon, and the whole objective is to not get into the tumor. And if these markers are placed into the tumor, your objective is to really not touch or really be quite near the reflector. Because it gives us the distance and you go back and forth with the probe, you're assessing. We're all trying to achieve a 1 centimeter grossly clear margin. So if your lesion is 1.5 centimeters, you're trying to take out a specimen that's 3.5 centimeters in diameter. So you're sculpting that lumpectomy specimen, and you're getting that signal. You know what your distance is. If you know it's been deployed in the middle of a 1.5 centimeter tumor, you're really trying to get a little, about a margin that's half the tumor diameter and the additional centimeter. So you're aiming for almost 2 centimeters around the signal site. So you're getting your good 1 centimeter margin around the tumor. So you have to assess the tumor size ahead of time, know where the scout is in relation to the tumor, and then know where you're going to be able to get a 1 centimeter margin around the tumor based on where the scout's deployed. If it's on one side of it, so you may be wanting to get 1 centimeter on that side, and if it's on the side of a 1.5 centimeter tumor on the opposite side, you're striving for a 2.5 centimeter margin, just so that your tumor ends up in the center of your specimen with appropriate 1 centimeter gross margin. Another avenue that I've used Scout for, now that it's MRI safe and it can be deployed under MRI guidance, and as far as I know, it's still the only localizing device that we can deploy under MRI guidance. For instance, we've had several cases, lobular cancers, where patients have opted for mastectomies, and on standard imaging, the area is really not as depicted as well as it would be on an MRI, and then we see trabecular patterns, reticular patterns of tumor kind of extending close to the skin. And so I've put scout markers in the skin by MRI guidance, because you're not seeing this on standard mammogram where these little finger-like projections of lobular cancer are going right up close to the skin. And so I've put scout markers just under the skin in those areas by MRI guidance, and then we resect that little bit of skin. And it doesn't affect the cosmesis at all, because you're taking a very small portion of skin, but you're taking the skin on a mastectomy where the tumor is technically going to be the closest. And in these patients, we're able to defer radiation for a close margin. We know one of the indications for post-mastectomy radiation is a close margin, certainly under 1 millimeter after a mastectomy. And so I know a case, and we had talked about it earlier, where we're able to get a perfect margin. It was less than 1 millimeter on the skin, and every other margin was great, and the patient did not have to undergo radiation. Adapted my practice to use Scout for other situations. I recently had a patient that was referred to me, and again, I'm a surgical oncologist, so I do more than just breast. So I had a patient referred to me that had had a history of Hodgkin's lymphoma. She was doing fairly well, asymptomatic, but on a staging PET scan about 2 years out, had some retroperitoneal nodes that were active on the PET and highly suspicious. They did CT-guided biopsy twice and got a non-diagnostic answer. The PET SUV was really suggestive that there was a recurrence here. So the medical oncologist said, "Can you get me some of these nodes?" And I was like, "Yeah, I can get you some of these nodes." And I go, to make sure we're getting the nodes that are active on the PET, because the patient had several enlarged lymph nodes on the CT, but only a few were active on the PET. I go, to do this, I go, let's put a Scout reflector. So we came in from a posterior approach with the patient prone, deployed a Scout reflector right behind, posterior to one of the retroperitoneal nodes. And what I found is I got a great signal. It was a relatively thin patient, and I got a great signal from the anterior abdominal wall. Made about a 5 centimeter incision, supraumbilically in the midline. And this was a lymph node that was just inferior to the left renal vessels. And so by Scout guidance, we were able to go directly to it, minimal disruption of normal tissue, get the lymph nodes, and prove that the patient had recurrent Hodgkin's lymphoma with a very minimally invasive surgery. So when I was doing the case, I'm getting the signals, wasn't really sure which one I was getting sometimes, if I was on the superior one or the medial one. And so this new platform will allow me to say, that's the superior one, that's the medial one, that's the lateral one, that's the inferior one. And so to have that option, I've never done a case where I've used more than 4. So having 4 different signals and telling me which one that is also going to be a huge advance in in these type of surgeries. And we're doing more and more of these because patients are asking for it. So is there any in between having a mastectomy and reconstruction and not necessarily having to need a mastectomy with a larger tumor?